Hello and good morning. Thank you for your time. I've worked with some of the people in the room. I am a City of San Francisco registered nurse. My name is Jennifer Steen. And I'm really sad that Jeff Kozitzky left. I think it's a little disrespectful to the people. So I want to start by reading from the SF Administrative Code, Section 15.23, Mental Health Services for Indigent and Uninsured. If timely, effective, and coordinated mental health treatment is not provided to indigent and uninsured residents who are not seriously mentally ill, those residents are at risk of becoming seriously mentally ill and hence requiring more expensive and comprehensive mental health care from San Francisco. I think we knew what we were doing in writing the code, and I think it is incredibly important to remember that. So I think asking about the budget is important. The homeless budget is over $200 million. The DPH budget is a little over $2 billion. It's a 10 times discrepancy, but DPH serves so many more people. Homelessness has lots of money and is not utilizing it well. I think, as everyone here said, I agree with quite strongly that levels of care are lacking in all levels and that people need to be able to be supported so that they can exit. I think, Supervisor Ronan, you've asked many good questions about exiting. And right now I work in transitions, which is placement. Exiting is a problem. We do not have enough beds. There was a work group that conducted a study. If you need a copy, if you have a copy, I can provide it for you, with multiple recommendations about where beds are needed and can be provided with a cost breakdown. This work group put together this draft. Someone sent it to me anonymously. I don't know where it came from. I wasn't privy to it as a person who works for transitions, which is quite disappointing because I think this is the kind of information that needs to be disseminated to staff as well as people we serve. I know the bell.
Chair Mandelman, could I ask a question?
Sure.
So working in transitions, what's your number one recommendation of where we should be focusing in terms of building up capacity in our system?
I think capacity is the biggest issue, and like it was mentioned at all levels. I work specifically, transitions we authorize for all levels. We authorize co-ops, support service hotels. We used to authorize for DA, but now that's gone to the Department of Homelessness. We authorize for residential care, dual diagnosis. We authorize for the 90-day, the ADUs. We authorize for board and care facilities and adult living centers. And the problem is that we don't have enough beds. So the log jams that exist at both Laguna Honda and at San Francisco General are a result of not having places for people to go. We can continue to put people on 5150s. They can continue to have a need, but we opened up the Healing Center to create capacity. We've opened up Hummingbird to create capacity, but all those folks are still stuck in those new beds. So we've opened new beds, but they're ready to graduate and have no place to go. So the ask is all the levels. We need support service, hotels. I think Jeff Kozitzky made a really great numerical statement in that 800 more beds are opening every year, but those beds already existed before the department was created. Department of Public Health was not mismanaging those beds. The target wasn't strict homelessness. And right now, I think it was also stated that the departments aren't communicating to figure out who is in need. So we can look at length of homelessness, but if we're not fully coordinating the overlapping needs of mental health care, medical health care, dementia diagnosis, which is almost impossible to place, ambulatory issues, which makes it secondarily impossible to place, and if you're incontinent, then you can't even go into a residential program if you might need it, if you can't climb stairs. Because in San Francisco, everything's on a hill. Most buildings don't have elevators, so people can't get access to programs. So we would need some other differentiations that I think sometimes not necessarily obvious to our leadership, but maybe more obvious to people who are actually doing the work or utilizing the services, that if you have an issue, if you just walk with a cane, you can't go into a program. And I think something else has happened. PES used to be able to refer directly to Progress ADU beds and cannot do that any longer. So we're seeing that a lot of clients, if you go into inpatient, you can be referred, but only for the first 7 days of your stay. So people actually are not able to even make that simple exit. ADUs are called acute diversion units, and they were designed and created as an outlet for PES. And now it's not being utilized that way. I don't know what the decision-making is that went into that. I'm sure it's multifactored, but it's also problematic.
I think
Good point.
Supervisor Stephanie has a...
I'd just like to thank you for your comment. I definitely want to follow up with you. I'd like a copy of that report. I have my card, but I definitely would like a meeting with you to discuss that further. So Thank you for coming today.
Thank you very much.
We probably all would like to see that report.
All right.
Next speaker.